welcome. And we are going to have Destiney McAuley be our first speaker. Come on up, and she is going to give us a case presentation on a patient in cardiogenic shock.
Good morning. My name is Destiney McAuley, and I am a registered nurse in the Heart Failure ICU at Memorial Hermann, the medical center campus, right here in Houston, Texas. I first want to thank the organization for allowing me the opportunity to speak today, and also thank you to the panelists. Sorry, get the mic in the right place. Thank you to the panelists in the audience for listening. Let's get started. Okay, let's start with some situation. Our patient, who I will refer to as our patient, or by the initials MW for the duration of the presentation, is a 61-year-old male, African-American male, who presented to the ED with complaints of general body aches and congestion. Upon chart review, we saw that the patient had quite an extensive heart failure history. So once we ruled out the usual suspect being flu, COVID, et cetera, we decided to do a cardiology consult just to make sure or rule out whether or not CHF exacerbation would be the reason for the symptoms. Moving on to background. Our initial laboratory data gave us a little bit more to work with. Specifically, the proBNP, which is the gold standard biomarker in heart failure, was elevated to a whopping 25,646 picograms per milliliter, and the serum lactate was also highly elevated at 7.1 millimoles per liter, both indicating our patient was in severely decompensated heart failure and cardiogenic shock. Combined with the chest x-rays showing gross cardiomegaly and pulmonary edema, as you see here, our patient was admitted to the Heart Failure ICU for further investigation, closer monitoring, and management of his symptoms. Continuing to investigate our patient in cardiogenic shock. Following our practice directive, an echocardiogram and right heart cath were ordered and confirmed the diagnosis of cardiogenic shock in the setting of advanced heart failure. The echocardiogram showed 4-chamber dilation and reduced function of both the left and right ventricles. There also was multiple things that showed evidence of fluid overload in the study. Our right heart cath established that our patient was also in a low cardiac output state. The FIT calculation was only 3.68 liters per minute cardiac output, and there was insufficient tissue perfusion as evidenced by an SpO2 reading of only 55%. Based on these findings, the team proceeded to add continuous IV diuresis and also reinitiate milrinone into the patient's care plan. Our patient had previously been on home IV milrinone therapy, but was recently weaned off, and he also had a CardioMEMS implantation just 7 days prior to this admission. A Swan-Ganz catheter was placed for continuous bedside hemodynamic measurement while the patient was in ICU. It took by day 2 of admission for us to begin the advanced heart failure therapy workup on our patient MW. Just as a prerequisite to the conversation of advanced heart failure therapies and to add a little bit perspective, some background on our patient is that he was initially seen in our heart failure clinic to get a second medical opinion. He was evaluated for advanced heart failure therapies in another state, and although he was approved for heart transplantation, he declined just for some personal views on vaccination and his vaccination status. The patient had been at home on heart failure guideline-directed medical therapy, and again, he was on IV milrinone that had been recently weaned off per his own request to accommodate some travel itinerary that he had. It was against the medical team's suggestion to wean this off. However, the patient was safely moved and titrated on his GDMT. Advanced therapies also was a part of the conversation from initial presentation to our clinic and also in subsequent visits. Assessment of our ICU management in this patient. Following the modifications that were made, so that's initiation of the diuretics, restarting milrinone, and placing a balloon pump, we did see some marked improvements initially. The patient's lactate cleared to 1.7, and there was the RA pressure, or CVP, which we use as a surrogate in the ICU, had come down to normal limits. We also saw renal recovery in the laboratory data of creatinine and BUN on the patient. It should be noted that our patient MW was not exactly a typical acute cardiogenic shock patient. His bedside hemodynamics were never too out of whack, and we never had to start additional vasoactive medications on him. However, further investigative data via echocardiogram and right heart catheterization showed us what we need. After fine-tuning medications and trying to optimize over the following week or so, there was no improvement at all or a qualitative change in the echocardiogram data. So reference the video, sorry, I wanted to go back. If the patient still had 4-chamber enlargement and also severe and diffuse hypokinesis of all ventricles. The EF never improved to a state above 20%. During the preceding advanced therapy workup, there were some concerns over the patient's candidacy for durable left ventricular assist device, and the patient did refuse heart transplantation again. The patient comes in with some neurocognitive deficiency, and that was a barrier to whether or not we could determine he would be approved for an LVAD. So in an effort to try to optimize the patient on medical therapy, the balloon pump was removed and continued titration of the drips and monitoring followed. However, post-balloon pump removal, our patient remained in a state of slow and persistent cardiogenic shock, proving that medical therapy alone would just not be enough. At this point, full presentation to the medical review board to see what he qualified for was the only available treatment option. This slide just kind of goes over the things that we do that are a part of the inpatient advanced therapy workup. So we do multiple diagnostic studies, including CT scans, various Dopplers, of course, echocardiogram and right and left heart catheterizations. We also follow a multidisciplinary care team evaluation that includes palliative and supportive medicine, social work, the mechanical circular support team, and also the different rounding and consulting physicians. So what do we do? These figures here reference where our patient scored on the INTERMACS profile, which relates to him being high risk on optimal medical therapy over a span of time and his appropriateness to move forward to mechanically assisted circulatory support. In the setting of refractory cardiogenic shock, we consider these numbers to see the patient's appropriateness for moving towards something more long-term. Based on his clinical presentation, he was an INTERMACS 2, which showed declining function despite IV inotropic support. I want to point. The second figure here on the right follows the algorithm for management of these patients that scores an INTERMACS 2. So for our patient is here 2, the recommendation is temporary MCS, which we did in the form of a balloon pump, and then later on in the admission, an Impella percutaneous LVAD. What we saw was that the patient did have some end organ repair. The renal function did improve, however, there was no cardiac recovery. This step would have us evaluate if the patient is appropriate for a heart transplant, but since the patient did deny, it left us with the only option of a durable LVAD as a destination therapy. This is a brief overview and timeline of our patient's hospital course. Here shows his admission and when we started advanced therapy workup. There were many presentations to the medical review board that were indeterminate before the patient was finally approved, and then he was transplanted. I'm sorry, implanted with the device, not transplanted. He did not want that. Should note that our patient did have a complicated course, so there was 7 weeks of fine-tuning and titration that happened in the time that the patient presented until the time that he was discharged. Our patient persisted in a state of shock as evidenced by followed-up echocardiogram data, and that the patient showed no improvement. The care was complex, However, it was without serious event, and we were able to move forward confidently, knowing that the investigation that we did proved that a left ventricular assist device would be enough. Just to give an overview, our patient did have persistent heart failure with a reduced EF. He remained in cardiogenic shock with intermittent lactic acidosis. We had complication managing IV diuretics. The patient had pulmonary edema, transaminitis, and a multitude of different things that are representative of a patient in cardiogenic shock in the setting of advanced heart failure. However, we did get a happy ending. The patient did get implanted with a HeartMate 3 durable LVAD on January 25th of this year, and after a couple of weeks of optimizing, fine-tuning, and one reintubation, he was discharged to inpatient rehab and eventually home last month on the 26th.
That's awesome.
Thank you guys for listening to the case study presentation, and I'll entertain any questions.
That was awesome. You guys can hear me okay? That was a great case. I mean, there's about 1 million questions that I think probably everyone here in the audience has, but I think that was a great sort of lead into all these different talks for the rest of the day, so bravo for that. In order to get us back on track, probably just cut the discussion a little bit short, but I thought I'd ask one question of the panelists and everyone here, just because it's not going to be discussed in the next couple of talks, and that's about identifying the shock patient. I mean, you highlighted this very well in a couple of slides. Everyone's going to hear about these fancy tools that we're going to be using, these fancy lab tests that we're going to be using in the future, novel ways to manage these patients. But in my mind, it ultimately boils down to still being able to identify the shock patient, the cardiogenic shock patient. And that is a problem that we continue to have, right? And if you don't accurately and efficiently identify these patients, you've changed their course dramatically, and it can be quite bad. So I'm curious from everyone, including yourself, are there any features, historical features, presenting features when the patient comes into the emergency department or wherever that you really sort of hang your hat on to help as sort of like a guide that, hey, think about cardiogenic shock in this patient? I mean, anyone on the panel here?
I feel like, sorry, I don't have to turn it on.
No,
I'm probably loud enough that everybody can hear me anyway, in general. People who know me would say that's very, very true. I think that we focus so much on right heart failure because we see it so much that I think that we tend to look for it more than a lot of other centers, and I think that we're more successful because we're so aware of right heart failure, and we have a great pulmonary hypertension team as well, so it actually helps us to really focus on that stuff. So I think our ability to see all these shock things, the low cardiac output and index, how it presents in a person without those things attached to them yet, looking cold, a little bit mottled, mentation is not the sharpest. All the sort of basic stuff we start with and start, coming at physicians saying, hey, just come look at him because I think we need more information on this gentleman because his family's saying he was this way and this is how I'm finding him. And we're really, really lucky to have the physicians who are very open to that discussion. And if we say, come look at this gentleman, I'm concerned, they're there. There's no question that our opinion is valued and it is to be investigated clearly. Because we're lucky to have these people who believe in us and listen very carefully to us because I work with wonderful, wonderful people. So I think we start at the basics, and then as you add information, we're really proactive. Yeah. So as we see those symptoms change, and as the CVP goes from 9 to 10, and the waveform changes into looking very stiff, most of us will recognize that and start the conversation early. Yeah.
And I'd say, I think one of the things that I think we undervalue as providers is the nursing spidey sense. And I'm guessing everyone here knows exactly what I'm talking about, where something just isn't quite right.
Yes.
And that's really now been discovered to be that shock stage B, where if you discover them early, they don't actually meet that true physiologic exemplar of cardiogenic shock stage C. And so, at least at my institution, we actually now empower floor nurses, ED nurses, whomever, to activate a shock call and to activate the shock team if they're concerned that their patient is early shock. Because we recognize that the nursing staff are the ones who are at the bedside 12 hours a day, whereas providers, we spend, 18 minutes on average with a patient? It's That's not untrue. But I think that you very well highlighted exactly a patient who came in extremis and you were able to take to that next stage and luckily didn't slide from that C to D to E, and you were able to get them through.
Yeah.
Yeah, we understand the nursing spidey sense too. And
Yeah.
the smart ones of us who
Yes.
listen to our mothers.
Yes.
It's the same that Barbara, just like Barbara mentioned, this is a patient because of his not atypical presentation who could have been missed. But because our institution, we're fortunate that we're on so much of the cutting edge of heart failure and there's so much knowledge. These general symptoms of like just congestion, if a patient is having some bowel disturbances, these things are gonna alert us that something else is going on. So along with the chart review, you're like, you know what, let me see if there's something else to this. This patient wasn't crashing and burning. We didn't give a fluid bolus and then see things go the opposite way. This is a patient that just has a long-standing heart failure diagnosis that had been worked up and discussed for many years. So just have somebody being in the ED, having that keen intel to let me look at the chart and say, you know what, this might be something. Like a patient needed constant hemodynamic monitoring and they placed a cardiomems just a week ago. What's going on here? So I think that part is just like, we're just lucky, you know, that we were able to, because this is a patient that was to the brim. You know, EF was 15%. Had he kept going on as he was going outside, then he would have been in that situation that would have been extremely hard to treat.
I'm so happy you said that. You said what I was hoping someone would say, and that is the historical aspect of the patient, his history, spending just a little bit of time reviewing the history, knowing this is a patient with a chronic cardiomyopathy, knowing this is a patient that has had decompensation, should key the entire team into that this potentially being cardiogenic shock. So it's one of those features. The other thing that you had mentioned, and then we'll move on to the next, is what's the experience at your institutions with doing point of care ultrasound early in the emergency department? Are you guys empowered to be able to do that?
Yeah, I think we were talking about this earlier. We actually have credentialed and privileged all of our APPs, whether they're in the ED or the ICU, to do POCUS, and all of our hospitalists on the floor do them as well. And so we actually have a method where we can actually save those images so that we can actually view them in our Epic system.
Nice.
And so we're very early adapters and
Amazing.
adopters.
There was one done in the ED on admission. I failed to highlight that, but they saw, of course, a large IVC and there was B lines present. So they had some more data there just from being knowledgeable about what's going on. So
Sounds good. Thanks so much.
thank you so much.